So we'll have a short class just to cover up all the topics that probably might have been left and maybe some part of understanding. So uh, we'll just revise the topics of molecular medicine and then follow it up with not exactly MCQs, but I have something different for you this time. Uh, how many doctors are here today?
11.
Okay, okay, all right. So basically, in medicine, we have all the topics deep down into biotechnology and genetics. So we did a lot of questions in the last class and learned about some techniques which are very important in diagnosis of certain cancers and certain hereditary diseases and certain congenital diseases, certain genetic diseases, and gene therapies and newer pharmacogenetics, which is coming up in a big way and is being asked in the exam. So these are the topics which are not even discussed usually and routinely in our MBBS and MD classes, but yes, they are important because they are a window into the future. So we'll begin with the genetic testing techniques. We begin with the most trivial of them, which we have been learning since a long time, that is PCR. So basically, the PCR is what? It amplifies the specific DNA sequences. So whatever DNA sequence you want, you put that small, it's called a piece of DNA. If it is there, you give them a medium. PCR is just like culture. We do culture of bacteria, we take the sample, we put them into petri dish, into a culture medium which we perceive that would be helpful to let the bacteria grow even more. Same way PCR, we take the DNA sample or whichever sample we have and put it into our medium in which there are multiple nucleotides and nucleosides which are available for ready replication, and then we have a polymerase enzyme, DNA polymerase in it. What happens is this DNA polymerase, it tries to get the nucleotides and attach them on the sequence as far as the present, I'm not getting that word, that small part of DNA, the probe, the DNA probe which is delivered into the medium, and then it amplifies those sequences only and helps us to diagnose those conditions which are very difficult to diagnose, like HIV. Sometimes HIV you can diagnose only by presence of the viral particles. And how do you define the viral particles? If the RNA or the retro RNA or the DNA is present. Same way these days, tuberculosis. If TB PCR is positive, that means the tubercular bacteria was there at the time of sampling. That is why its DNA was there at the time of sampling. And of course, genetic mutations. Then comes fluorescence in situ hybridization technique, which is called FISH. So in fish, this fish detects chromosomal abnormalities. So chromosomal means big chromosomes. For example, BCR-ABL translocation in acute myeloid, in chronic myeloid leukemia, presence of HER2 gene in breast cancer. This was fish. Then comes southern blot. Now, southern blot is basically for DNA. So it detects DNA mutations. For example, multiple repeat expansion, trinucleotide repeat expansion like Fragile X syndrome, Huntington's disease. These are the diseases which utilize southern blot to diagnose. So many times this question comes, what is southern blot? What is northern blot? What is western blot? What is southwestern blot? What is so northwestern blot? So southern blot is DNA, western blot is protein, and northern blot is mRNA expression. So northern blot is where we measure the mRNA expression levels. Where should it be used? It should be used in enzyme deficiencies. Why? Because enzymes are all proteins, and proteins are produced by the process of translation. And translation is done on a mRNA which attaches to the ribosomal complex. So if the mRNA is there, only then the protein will be there. For example, if I say that a patient has a certain enzyme deficiency, then how do you define that this protein is not being synthesized only if the mRNA levels are not there? If the patient does not have any mRNA, that means the gene is deficient. But if the mRNA is there and the protein is not being synthesized, then we find that there is a problem with the translation. That is, mRNA is not being translated into the proteins. But if the gene is deficient, then mRNA will also not be there. So if you check the northern blot and you do not find any mRNA respective to that protein, that means that directly it tells you that this is a protein which is totally deficient in this person. And if you are having a enzyme, having a treatment, a medicine, a molecule which is to be given to that person which utilizes that enzyme, then what will happen? That medicine will be rendered useless because that enzyme is not there. Because either we cannot check that enzyme level in the blood, or we are not getting the mRNA also in the northern blot of the patient. Western blot is to identify the proteins. Now it uses antibodies, for example, HIV confirmation, prion diseases. These are Western blots. So you identify antigens like HBs antigen, hepatitis B surface antigen. Students don't ask how is that done, sir. That is done by blot method, Western blot, because that is a protein, and protein is identified by Western blot. Then comes the easiest test of all, which is ELISA. Now, ELISA detects all the proteins and antigens. It is easier to perform. Everybody is doing it. ELISA changed everything. You can diagnose almost so many infectious diseases using ELISA now. This enteric, this HIV, this hepatitis, so many autoimmune diseases that you diagnose with ELISA. Then comes microarray. Now, microarray is basically microanalysis. So you go down into the DNA and uh, into the chromosome and find specific genes, and those genes you detect their mutations. So it is a screening tool. It is not a diagnostic tool. It is a screening tool. It screens for multiple gene mutations simultaneously. So let us say you have a cell, a tissue in the breast, which you want to diagnose for the presence of gene for HER2/neu, for mu receptor, for estrogen receptor, for progesterone receptor, ERPR. Then how do you do that? You screen them with microarray. If the microarray uses and multiple gene mutations like BRCA1, BRCA2, simultaneously you can test with the microarray test. For example, cancer profiling and using them in pharmacogenomics. Nowadays, it is an upcoming branch where the drugs will be synthesized as per the individual's genetic makeup. Then is karyotyping. Karyotyping is a very beginner level diagnostic technique where you actually detect gross chromosomal abnormalities. For example, XO. So one X chromosome is absent. How do you do that? You don't need to do gene mapping here. You don't need to do microarraying here. You don't need to do ELISA here. All you need to do is karyotyping. 20. Down syndrome. So 13X. Okay. So this was about the genetic testing technique. Then comes the molecular oncology and using the pharmacoagents for targeted therapy. In this, the leader is CRISPR-Cas9. So this is basically a gene editing tool. Nowadays, everybody is using their mobile phone to do photo editing tool. So there are filters, there is, you can copy the pictures and do everything with a crop tool and all. Same way, CRISPR-Cas9 is a format where they are using micro scissors. So these are gene editing tools which allows precise DNA modifications. And you can, for example, somebody has a gene which has a mutation and that mutation is causing cancer. So if you can just use these micro scissors and cut out those portions which are causing the cancer, then probably you can treat the person. For example, let us say here is the problem. So in CRISPR, what you can do is you can simply take out this portion using the micro scissors. And then when this is removed, it will reunite it like this. And the blue portion is literally lost with the seizures. So that is lost. Hence, this uh, mutated gene will be taken away, the oncogene will be taken away, and the cancer potential will decrease. So these are the newer interventions that will be utilized in coming future, and they will become a routine things. Then comes RNA interference, that is siRNA. This is to use what? This is the RNA which is uh, going to connect with ribosomes and produce a protein. Now, if I use an anti-RNA and it binds to it so that it cannot enter into the ribosomal complex, then what will happen? The gene is there. It is this DNA is there. This is producing the mRNA, but this mRNA cannot translate now. That means we have saved somebody from a potential gene mutation related disease. Now the patient cannot produce that protein because we have blocked that protein synthesis at the level of the mRNA ribosomal complex formation. Now, this would help in management of diseases like Huntington's disease, like the Alzheimer's dementia, because tau proteins are getting deposited there, and proteins are being translated from some RNA only. No, some mRNA only makes some proteins, and tau proteins and these TTR, so genes which are now, we understand that they are the ones which are producing amyloid. So you can block the production of those proteins by using RNA interference or siRNA. Is that clear till now? Yes. Then coming to oncolytic virus therapy. Now, these are engineered viruses. You all know that a virus is like a nucleoprotein molecule. Now, this virus has a DNA inside. This virus has a DNA inside. Uh-oh. This virus has a DNA inside. Now, what will happen is, for example, if we have given it to someone, and this virus has receptor only for cancer cells. For example, this is the cancer and this is the receptor. So this virus will go and attach here, and there will be this DNA. Now this DNA will be introduced into this cancer cell, and this DNA will align itself with the rest of the DNA of the cancer cell. Now what will happen is, this virus will ultimately make its own DNA. So it will utilize the cancer DNA to make its own DNA, until what will happen is, this will explode the cancer cell, releasing further copies of this virus. So, and then this will continue to infect the cancer cell and killing it completely. So there are chances that this one can be used. In fact, one of those molecules, those oncolytic viruses, are already in use. For example, in melanoma, which is a skin cancer, and the virus is Treg. Then comes a CAR C cell therapy, where what we have done is we have altered the T cells. Now we understand the T cells are either CD4 or CD8. Now CD8 cells, they are basically killer T cells. They are the ones who are responsible for killing the cancer cells. And CD4 are basically for stimulating the B cells. They become memory cells and letting the antibodies cascade. This is CD8 is the killer cell. It is helpful in managing cancers. So these T cells, if you can genetically modify them, then they can be used. For example, B cell lymphoma mein CD19 wale altered T cells can be used. And then definitely everybody nowadays knows that monoclonal antibody therapies are being used, which are known as biologicals therapy, biologicals or immunologicals. This is what they are told. So these are target specific antigens. For example, trastuzumab is the most famous HER2 new breast cancer drug. So these are chimeric molecules, and they are a big name now because they have helped treat so many people with least of the problems of chemotherapy. Then adeno-associated viral vectors. This is also used in gene therapy, trying to eradicate or modify the gene. So used in Duchenne muscular dystrophy. Then coming to newer further techniques, which are pharmacogenomics or precision medicine, where you understand the condition and disease so much so that you know that you have to block the mutations. These are the drugs like EGFR inhibitors. So wherever there is something known as EGFR, endothelin growth factor uh, receptor, wherever this is there, and it leads to proliferation of the cancer cells, for example, non-small cell carcinoma of the lung, then these EGFR mutations can be blocked by erlotinib or gefitinib. These are the newer drugs, again biologicals. Then KRAS mutation testing. KRAS mutation is basically it provides resistance to the anti-EGFR drugs. So these are the EGFR inhibitors. So if somebody has a KRAS mutation, then this EGFR receptor will be altered in structure. So KRAS mutation should be tested before using any anti-EGFR drugs, specifically in colorectal cancer. So this is its use. When we saw why are our drugs failing in colorectal cancer, when it there is a potential pathway of EGFR receptor, and the drug should be blocking it. But what is happening is that the receptor has altered its structure due to the KRAS mutation. The gene got mutated, the receptor got mutated, and hence our drugs which were going to bind to the KRAS receptor cannot bind anymore. So the drug will be ineffective. It is prudent, it is wise to test all these patients of colorectal cancers if you are going to give them KRAS anti-GFR drugs, to test them for any KRAS mutation. Same way, CYP cytochrome P450 enzyme testing. Now, who knew that somebody who is given clopidogrel for keeping the cardiovascular coronary stents open will be rendered ineffective and the clot will be formed? Why? Because clopidogrel is not showing its effect. Why? Because the patient has a defective cytochrome P450. So the metabolism variability can be predicted if you can check cytochrome P450. Same way BRAF mutation testing. Why? Because BRAF mutation, if present in melanoma, it is an indicator that it will respond to a drug known as vemurafenib. Then TPMT enzyme, everybody knows it. It has been asked in the exam for last 5 to 10 years now. So TPMT is thiopurine methyl transferase enzyme. It is absent in certain population, and when the TPMT is absent in that population, if you give them azathioprine, they can develop bone marrow depression. Why? Because azathioprine azathioprine is a drug which is used in so many autoimmune disorders, even rheumatoid arthritis, SLE, Sjogren syndrome, myasthenia gravis, so many drugs, so many conditions. This drug is used. That if the TPMT is absent and you continue giving azathioprine, it will not be metabolized in that person, and it will start showing its toxic effects, leading to bone marrow depression, hepatic failure, and so on. So it is very, very important to test for TPMT enzyme activity. Then HER2 new testing, PR, ER, receptor testing. This is very important now because we have to give a drug which is known as Herceptin, trastuzumab, in breast cancer. If HER2 receptor is present, then it will show its effect. If it is not present, then it will not. Then checkpoint inhibitors, new drug, pembrolizumab. Pembrolizumab is the drug of choice now, which is used for a condition known as triple negative breast cancer, TNBC. So you should check that patient has the PDL1 expression. If the patient has PDL1 expression, then pembrolizumab will be working very good. It is used in NSLC, melanoma, breast cancer, triple negative breast cancer. So very good drug these days used. It is expensive, but is effective. Same way, ALK inhibitors like crizotinib, elastinib, these are used in non-small cell cancer of the lung. Then comes the inherited disorders. So, as a part of molecular biology, as a part of molecular medicine, as a part of biogenetics and the branch of medicine which deals with it, these are very important because these are the conditions which are non-communicable disorders, but they are inherited and they are have a concrete genetic basis. So we do not have treatment for them as of now, but as the genetics progresses, we may have treatments to these conditions. So you need to know what is the genetic basis of these diseases, and this will be asked again and again in the exam. So for the referral and memory sake, Huntington disease is CAG trinucleotide repeat expansion in HTT gene, leading to progressive neurodegeneration, and in Huntington disease there is Huntington's chorea, dancing purposeless movement. Cystic fibrosis has a gene mutation in CFTR, which is a chloride channel receptor gene, leading to thick mucus formation, and thick mucus plugs all the tubes, be it bronchi leading to lung infection, be it to pancreatic duct leading to pancreatitis, be it irritated testis leading to testicular insufficiency. Duchenne muscle dystrophy, the DMD gene is deleted, loss of dystrophin, leading to progressive muscle weakness. Gover sign is the uh, point to be remembered. Marfan syndrome, fibrillin 1 gene, connective tissue disorder, hyperelasticity, risk of aortic aneurysm, aortic regurgitation, and the cause of death is usually rupture of the aortic aneurysm, and cardiovascular cause is the biggest reason for death. Sickle cell disease, everybody knows it is a hemoglobin beta gene mutation. Glutamine has valine at position 6. RBC undergoes sickling wherever there is hypoxia or oxidative stress, leading to vaso-occlusion and hemolysis, and vaso-occlusive crisis, and hemolysis, jaundice, and sometimes death. Familial hypercholesterolemia. Nowadays, we know that this LDL receptor mutation, inclisiran, is a drug these days which is used. It is injectable and it is gene therapy kind of situation. Early onset CAD is seen in LDL receptor mutation. So people who could not get treated with statins and azitamib and newer drugs like bempedoic acid, we need to go for inclisiran like therapy. Hemophilia A is factor VIII deficiency, X linked, runs in the families. It's basically royal family disease, bleeding tendency. Then cancer condition, Lynch syndrome, hereditary non polyposis colon cancer, mismatch repair gene mutation is there, and the genes are MLH, MSH1, and all. So you need to remember that genetic testing is the window to the future. It helps in diagnosis, prognosis, and treatment decisions. And because PCR is available in 2 hours, it is the rapidest way of diagnosing a condition, infective or cancerous. The only thing is that we do not have enough copies of the DNA segments probes till today. But as and as the medicine, the genetics progresses, we will have the genetic probes to almost all the medical conditions, and we will soon have very quick diagnosis. Like in COVID, COVID was PCR. No, we could establish the diagnosis within 1 hour. Then also it helps to provide targeted therapies against cancers, against maybe HIV also in coming years. Pharmacogenomics allows personalized drug therapy. For example, some people who are TPMT negative, you should never give them azathioprine or mercaptopurine. Same way, gene therapy and genome editing like CRISPR Cas9 will be holding future promises in the field of medicine. Now, I would like you to turn on your mics whenever you want to answer, because now we will have certain questions just for your refurbishing your concept clearance in the molecular medicine. So we will have certain options for questions 1 to 5. We will have 8 options for every 5 questions. One is polymerase chain reaction. The second is fluorescence in situ hybridization fish. Third is southern blot. Then is northern blot. Then is western blot. Then is ELISA, microarray, and karyotyping, like all the topics that we read in the genetics component. So you need to tell me which of the following matches the clinical scenario. So a 5-year-old boy presents with developmental delay and large ears. The genetic test is performed to detect trinucleotide repeat expansion in the FMR1 gene. So which test will you do? Anyone? Which test will be used? Yes? Yes. So we will be using southern blot for reading the trinucleotide repeat expansion. So C is for number 1. Second is a patient with suspected CML undergoes a genetic test to detect BCR ABL translocation. We need a chromosomal analysis here. Fish. Wonderful. So the answer will be fish. Third, a researcher is analyzing mRNA expression of various genes in tumor samples from breast cancer patients. Northern blot.
Northern blot.
So northern blot is mRNA. So this is northern blot. D. A newborn presents with ambiguous genitalia
Karyotyping.
and a chromosomal analysis is,
Karyotyping.
so it is XO. We need to understand the largest size which we can determine, that is by understanding the chromosomal. So that is karyotype. A patient with suspected HIV infection is tested for viral antigen level in the blood. So HIV P24 antigen we want to test. How can we do that? Easiest way is?
Yeah.
Elise.
So easiest way is?
ELISA.
Elisa.
Okay, good. So let's see explanations. So first is southern blot used to detect trinucleotide repeat expansions. The diagnosis in this case is Fragile X syndrome. Okay. So second is to detect chromosomal translocation. BCR-ABL is fish. Third, to analyze the mRNA in tumor samples from breast cancer patients is northern blot. To detect XO Turner syndrome ka diagnosis, the answer will be karyotyping. And to define the antibodies or antigens in blood levels, you can do ELISA. Very good. So molecular oncology and targeted therapy. So we have CRISPR-Cas9 RNA interference, oncolytic virus therapy, and CAR cell therapy, monoclonal antibody therapy, small interfering RNA, siRNA, adeno-associated virus vector, or gene silencing. So we'll have few questions, clinical scenarios. A patient with relapsed B-cell lymphoma is treated with genetically modified autologous T-cell expressing a chimeric antigen receptor targeting only CD19. So we are using a T. So what is the answer? So it, so it is?
Art.
The answer is CAR cell therapy. So we are using specific T cells targeted against a specific receptor, T cell receptor. So they were known as TCRs. So these T cell receptors are present. CD19 is a T cell receptor. It is present on the B cells, which are basically causing B cell lymphoma. So we use CAR cell against CD19 to kill these B cells, because these T cells are basically killer T cells, which are CD8. Okay. A novel therapy is being tested in glioblastoma, where a genetically engineered virus is used that selectively infects and lyses tumor cells. So we are using virus. Which of the following is the
The
answer?
G adeno associated virus vector.
So one is saying adeno associated. So other is oncolytic virus therapy.
Virus therapy.
So here we are basically lysing the tumor cells. So this is more likely to be oncolytic virus therapy. We will see. A genetic disorder caused by mutation in dystrophin gene is being treated by delivering a corrected copy of the gene. This is adenovirus, because adenovirus is usually, in fact, so many organ systems. So is the adenoviral infection occurs, liver gets involved, kidney gets involved, eyes get involved, every tissue gets involved. So whenever a multi-organ virus is used, that is specifically used to alter the gene structure of the body. So a genetic disorder used to correct the dystrophin gene is being treated and delivering a corrected copy of the gene using a viral vector. This should be adenoviral vector. Let's see. And this should be a oncolytic virus, where the lysing of tumor cell is happening. Here, a corrected copy is being delivered. So we are actually making a healthy chromosome, healthy DNA. A new technology enables precise gene editing by utilizing a guided RNA and endonuclease enzyme. This is
CRISPR-Cas9.
this is classical CRISPR-Cas9. A patient with HER2 positive breast cancer is treated with a therapy targeting HER2 receptor.
Fab.
That is
That is
monoclonal antibody, that is trastuzumab.
trastuzumab.
It is a it is Hercept. It is named Herceptin, I guess. It is named. Okay. So answers are that CAR cell therapy for genetically engineered T cells targeting CD19 and B cell cancers, and oncolytic viruses where engineered viruses selectively target and kill tumor cells. Adeno-associated virus vectors are used for gene therapy, where the genes are being made into better genes with the help of adenoviruses. CRISPR-Cas9 is genome editing technology modifying defective genes, and monoclonal antibody therapy is trastuzumab Herceptin that targets HER2 new receptor in the breast cancer. Okay. Now is basically more of a rota. So EGFR inhibitors, KRAS mutation testing, but you need to know this. I'll send you these immediately because later on I forget. So BRAF mutation testing, TPMT enzyme testing. So can somebody tell me EGFR inhibitors would be used in which kind of medical condition?
Gefitinib for non-small cell carcinoma lung.
Okay. KRAS mutation testing? So colorectal cancer? Colorectal cancers where we are using KRAS, anti-KRAS medications or KRAS blockers. If the mutation is there, the KRAS blockers will not work. Cytochrome P450 testing is done in which medicine? Which
Warfarin
drug?
Clopidogrel.
and
Warfarin.
clopidogrel.
Warfarin plus clopidogrel. And so many others also. But these are the main ones. BRAF mutation?
Melanoma.
Yes, melanoma. There is some drug known by the name of VER something. I don't remember. But it starts with V and it is a Zumab. Or NIB maybe. Something of that sort. TPMT enzyme testing?
Azathioprine.
It basically
Azathioprine.
and 6-MP
Mercaptopurine.
yes. HER2 testing?
CA breast. Trastuzumab.
Trastuzumab.
So which three receptors are tested in CA breast?
ER, PR,
PR and HER2
HER2.
new. HER2.
So if all these three are negative, then what is the cancer known as?
Triple negative.
Triple negative.
Breast
CFS.
cancer. Which is the drug which is promising,
Pembrolizumab.
and what is the pathway? There is a receptor which is tested in pembrolizumab, that is PDL1. These days, these all oncologists are getting it done. PDL1, checkpoint inhibitor, basically. Okay. Oh, we have it here. PDL1 checkpoint inhibitors for
Triple
pembrolizumab.
pembrol.
ALK inhibitors, even I don't know. It is probably small lung cancer. Okay. A patient with metastatic colorectal cancer is being considered for anti-EGFR therapy. Genetic testing is done to rule out mutations that confer resistance.
KRAS.
So the answer will be K.
KRAS.
KRAS mutation testing. A patient with acute lymphoblastic leukemia is prescribed 6-mercaptopurine. Enzyme activity testing is done to reduce the risk of severe toxicity. For which drug or for which enzyme?
TPMT.
TPMT enzyme.
Very good. A patient with metastatic melanoma is being considered for targeted therapy. Testing a specific mutation in MAP kinase pathway is done before initiating therapy.
BRAF mutation.
Wonderful. BRAF mutation. And the drug name again, I don't know. It is something nibormab. A patient with non-small cell lung cancer is tested for gene fusion to determine the eligibility for crizotinib.
EGFR.
EGFR inhibitors.
EGFR. Could be ALK also. We'll find out. This is so much of rectification, no? A patient with non-small cell lung cancer is tested for specific checkpoint ligand expression to assess response to pembrolizumab. Answer is
PDL1.
PDL1. So pembrolizumab is used for PDL1. So KRAS mutation testing is done for colorectal cancer, anti-EGFR. TPMT is for mercaptopurine thioxanthines, which is the azathioprine. BRAF mutation testing V600E is done to predict response to vemurafenib in melanoma. Very good. ALK inhibitors, ALK gene fusion is targeted in crizotinib in NSCLC, where we were thinking of EGFR. So remember that it is not the cancer which is important. It is the gene fusion and crizotinib. So you can remember that Alka is crazy. So that means ALK is crizotinib. So you can remember by this, ALK is crizotinib. It might trigger whenever you it comes across. So crizotinib is for ALK mutation. Is that helpful to remember?
Yes, sir.
Okay. So PDL1 checkpoint inhibitors, pembrolizumab targets PDL1 in NSCLC. Okay. Inherited disorders and molecular basis of disease. Sorry. Huntington's disease.
Yeah, the trinucleotide.
So trinucleotide repeat. Cystic fibrosis.
CFTR.
Duchenne muscle dystrophy.
EMT gene mutation.
Marfan syndrome.
FBN1.
Sickle cell disease,
HBE.
HB.
familial hypercholesterolemia,
LDL receptor mutation.
Mutation.
hemophilia A,
Factor 8.
Christmas disease,
Factor 9.
Lynch syndrome,
HNPCC, that is colorectal.
okay. A patient presents with progressive muscle weakness since childhood. Genetic testing reveals deletion in DMD gene, leading to complete loss of dystrophin.
Duchenne
Easy
muscular dystrophy.
questions. A patient comes with tall stature, hypermobile joints, aortic root
Smartphones.
dilatation.
Not fun.
Easy, no? So, not very difficult questions will come, but you will remember these because they will come. They are 100%. Out of these 20 questions, you will definitely find 5 questions or maybe 7. A patient with multiple family members affected by colorectal and endometrial cancer undergoes
Lynch.
genetic testing for MMR gene mutations.
Lynch.
That is Lynch. What are these MMR genes, anyways? They are mismatch repairs. What is this mismatch repair gene? Anyone? So when the DNA is being multiplied, no? The DNA multiplies in the same way. It has to match. So whichever part does not match, for example, so this part did not match. So what will happen is once this DNA and this cell is going to be released, before that a this mismatch repair gene will come. This will come and it is a scissor. It will take away this part and then connect it again, and so that the mismatch which was there is removed. But if the MMR gene is mutated or it is deficient, it will lead to more production of uh, defective DNA, leading to more proliferation of those cells. So colorectal and endometrial cancers will be there. Same way, cystic fibrosis gene mutation leads to the cystic fibrosis. Anyone who has a good knowledge about cystic fibrosis as a uh, genetic disease? Somebody wants to share?
Yes.
Go on.
Fibrosis patient suffer from.
So, number one, it is a genetic disorder. We must start like this. So, cystic fibrosis is a genetic disorder affecting the exocrine glands. This is very important to make a sequence in your mind. If you can make that, you very easily reach to the point where you can deliver anything on that topic. So it is a genetic disorder affecting the exocrine glands. That is why it leads to sticky and thick mucus wherever the tubular structures are there. So tubular blockages happen. Maybe bronchitis, maybe infertility, maybe constipation, maybe jaundice. And this is a genetic disorder because it is an enzyme related. Enzyme related disorders are usually autosomal
Recessive.
recessive. Structural are usually autosomal dominant. So, which is the gene? Now, when we come down to inheritance, so autosomal recessive, the mutation is in CFTR. So, it is cystic fibrosis transmembrane conductance. regulator. Conductance to which? Conductance to chloride. And which is this chromosome on which this gene is present? Chromosome number 7. Okay, chromosome number 7. And this mutation is known as delta 508. Is that clear?
Yes,
So
sir.
this is delta 508. So this CFTR protein is basically meant to regulate the transport of chloride ion, chloride channel. So this leads to, there is a pathway through which that chloride is less, so sodium is more. The water keeps on getting absorbed, and because of the excessive absorption of the water, then there is blockage by the thick mucus. Anybody who knows which test is to be done if the parents are known to have cystic fibrosis, and when it is to be done? So in newborns, you want to do number one, it is known as IRT. IRT is immunoreactive trypsinogen test. Why? Because it is tested in blood. It is elevated in cystic fibrosis. This is number one. Second is, how do you do that? You do gene testing, microassay, gene testing. You are specifically focusing on the gene. Let's go back. So what you see here is, so gene testing. Where do you see that? Microarray. You can check by the gene activity, or you can do it via a northern blot also. Is that okay? Yes,
Yes.
because it is a you can check the genes by northern blot, and if you are going to check for the CFTR protein, then you need to do western blot, but that is a far-fetched idea. But genetic testing is required to make the diagnosis. Okay. If there is somebody who has now grown up and is adult, then you need to do sweat chloride test. Okay. So what will happen to sweat chloride? Will it increase or will it decrease?
Chloride
Increases.
less.
So chloride is increased. So normally what happens is that in our the body is actually saving chloride. That is why CFTR is a regulator. So what will happen is, if the CFTR is not functioning, the chloride will be lost in the sweat. And if the chloride will be lost, that is why the water will also be lost. So water will be lost and everything will become very thick. So sweat chloride test, it should be more than 50 or 60 millimoles in the sweat. Normal is less than 30. So it should not be released out. Okay. Is there any treatment available? Anyone?
Yes,
What is the?
Ivacaftor and Lumacaftor.
Very good. Very good. So Ivacaftor, and the latest is Lumacaftor. Sorry, my spellings have gone. Lumacaftor. Okay. So Ivacaftor is used in some other mutation, but this Lumacaftor is specific for delta F508. All right. Rest everything is known to you. This was important, so I brought it up. Do you need discussion on any topic in molecular medicine? Any topic that comes to mind? If anyone has any question, any question. Okay, tell me why in cystic fibrosis clubbing is there?
Yes. Please repeat.
Why clubbing is there in cystic fibrosis?
Because of chronic lung disease.
Wonderful. And what will chronic lung disease do?
This chronic anoxia, hypoxia.
Why? Why did you say anoxia? Okay. Hypoxia, yes. So basically, what is clubbing?
Subungual proliferation of tissues.
Why does it happen? So chronic hypoxia, whenever what happens in retinopathy? Anyone diabetic retinopathy, because the pathway is same. What happens in diabetic retinopathy? Anyone?
This microaneurysm formation in the blood vessels.
Why? Because of vasculopathy. The blood vessels, they become narrow. So they cannot, it is basically a type of ischemia to the eye. So what happens whenever there is ischemia in any organ, the collaterals are formed. Now these collaterals are formed via a chemical which is known as vascular endothelial growth factor. And what is the biggest trigger for vascular endothelial growth factor? Sorry, where is my pen? So what is the biggest VEGFR, vascular endothelial growth factor? VEGF, sorry. So what is the biggest trigger for VEGF?
Hypoxia.
Wonderful. Hypoxia. That is why whenever there is hypoxia, the collaterals are formed. In heart, it is very useful. For example, the coronary, it is blocked here. Hypoxia will lead to formation of collaterals. This will help via VEGF. But the same process kills in case of retina, because retina is working on a different module. So if the blood vessels are formed in front of the macula, the vision is gone. Same is playing the part on the clubbing, because this tissue sorry, undergoes proliferation. And this is why it happens due to chronic tissue hypoxia. There is fibroblast proliferation in the nail beds. This leads to this clubbing. If you have any questions, please ask. If you need discussion on any point in molecular medicine,
The different type of DNA that is and RNA. What are the functions that are very often asked? Ribosomes, mRNA, DNA. If you throw some light on it.
okay. So basically, how many types of DNA are there? Two types, chromosomal and mitochondrial. Is that the way you are asking, or like the RNAs?
So sometimes it is asked that what are the functions where these introns and this sometimes this I have just gone through it, but it's not very much.
Okay. So basically, we will find a different page. So there is one to nomenclature is about the ABCD of the DNA.
Sir, what
So
are splicing and exons? All these things these are asked. These are asked in this past test question.
these
And
introns and exons.
yes, sir. Splicing. What is splicing? What is introns? What are exons? What are the
So
functions?
yeah, these are all basically part of the DNA proliferation or this PCR and all. So these whenever we are discussing about the genes, na. So what I'll do is I'll take a paper here and I'll discuss. So whenever we are discussing genes, so in the genes there are several portions, functional and non-functional. For example, whenever you go to a market, what you see is that there are certain shops and there are separators between the shops. That is a wall. So these walls are essential to keep the shops separate, isn't it? But
Yes.
these are not important as far as the marketplace is concerned, because they cannot be used for selling anything. This is a shop space which is used. So basically, these introns, these are called introns. These are intervening sequences. Intervening sequences. These are introns. So these introns, they are non-coding. Non-coding parts of the mRNA. Oh, of the gene. Non-coding part of the gene. So what does this mean? This means that every gene, now gene is not going to make protein by itself. It needs to produce an mRNA. That mRNA will go to the ribosome and make the protein. So in the gene, there are certain coding portions which code for the mRNA. Are you getting me?
Yes, sir.
But then there are these portions, the introns, which do not code, but they are structurally important to keep the gene in place. They are the non-coding regions. They are present when this gene makes a RNA. What happens? What happens that when the RNA is produced, they they produce their own segment, but these are non-coding parts.
Okay.
Okay, so this is the mRNA. So the gene has just produced a mRNA, and this mRNA has a, this is code. This is not a code. This is basically introns left over, whatever intron could leave an expression or an impression. What will help is the process is splicing, which removes these portions. And then you will have a clean mRNA. And the splicing procedure has removed all the impressions of the introns. So these are the intervening sequences, the introns. They produce non-functional segments on the mRNA, which are removed by the process of splicing. Is that clear?
Yes, sir.
Okay. Now, they can also lead to defective proteins. If the splicing gene is absent or the splicing enzyme is absent, what will happen? This mRNA will go like this, and this will translate into a different protein, a defective protein.
Okay.
Because this is the protein, this is the mRNA which could have made a correct protein. But if this goes with this, with the non-coding sequences, then of course the ribosome will go confused. What do I have to put into it? Are you getting my point?
Mm.
So, for example, there is a train with so many containers in it. These containers are all empty. So this is an mRNA. Ribosome will put their proteins, amino acids into it so that it becomes a protein. But in this case, the intron means already full chamber. So the ribosome will go confused. I had to put an amino acid here. How am I going to put an amino acid into a place which is already occupied? Are you getting my point?
Yes, sir.
So if the splicing doesn't happen, the protein becomes distorted. So these are mutations. These are abnormal proteins. So these these non-coding RNAs, if they become active, then they will lead to protein diversity. Protein diversity means several copies, phenotypes of the protein might be there. Is that clear?
Yes, sir.
And then the exons, this was about the introns. The introns are intervening sequences. Exons are expressive sequences. Whatever is expressed. So, what is the expression of gene? How does gene express itself? Gene cannot talk, but gene expresses by the way of mRNA. mRNA expresses in the way of a protein. So, these are the coding regions of the DNA or the coding regions of the gene. They are present even after the splicing, because splicing removes only,
It's non-coding part,
and they are known as
introns.
introns. So these exons, their the coding regions, they will lead to a presence of the mature RNA after splicing, and they will lead to functional protein. This process is known as RNA splicing. RNA splicing, which removes the introns. Is that clear now?
Yes, sir.
ये तो मुझे पता था. Anything else? So now you will not make a mistake, no? Introns are non-coding regions, exons are coding regions. Splicing removes introns from mRNAs to produce functional mRNA. Alternative splicing, which may produce defective or different kind of a protein because of the presence of non-coding regions. They can cause thalassemia, they can cause conditions like this.
Thank you, sir.
Anything else? Okay.
Yes. So
Fine,
what about
fine.
this receptors like immunoglobulin receptors for each disease like that?
You will have to download the chart and rectify it. There is no other way. There is no other
Okay,
way.
thank
It is so difficult. I personally, I remember only few of them. One of them was, Mali word, Mali. Mali is basically a gardener. Okay.
Mm.
And in the garden, uh, these sneezing is very common, right? Because of pollen grains. Yeah.
Yes.
Yeah.
In the garden, there are flowers. Flowers have pollens. Pollens lead to sneezing. Sneezing is basically a variant of asthma. And
Yes.
malizumab is used in asthma. This is a long way of remembering it, but it's a sure way of remembering it. Omalizumab is the drug which is used in IgE mediated asthma.
Yes.
I remembered long time back like this one. Because otherwise it is so difficult, you cannot remember all the names.
Very difficult.
Trastuzumab is very easy to remember because it has taken the world by surprise. But there are seconizumab, tocilizumab, so many zumabs out there, a man can go confused. But then you will have to find your own way to remember them. It is easier if you connect them with easier words, pick up some words like we just did. ALK receptor is what? Alka is crazy. So crizitinib, I may not remember the drug, but we can remember the association, right? What was the drug's name? Crizitinib, no? What was the name of that drug? But it was similar to it.
Creatinine.
Crizitinib only, no? So now we
Yes, sir.
remember. Now we remember. Now I will never forget. Alka is crazy. Alka is crazy. Okay, fine. Alka is crazy. I understand that. So ALK enzyme, whichever is there, the drug that blocks it, it is crizitinib. So it will only help you remember. So try to find some. This is ALK inhibitor here. Okay, so this is ALK inhibitor, and now I know. For my next class, I will remember it. ALK gene fusion is targeted by crizitinib. Easy. Same way, you will need to remember something like that. Otherwise, it is so difficult. Anything else in particular? Because I have given this exam myself, no, way back in 2016. I know where it hurts. This molecular biology is something that you will always try not to study because it is so panicking, but I tell you, because everybody will not study, and if you do it, you will at least make 80-90% correct answers. That is
So what about this morphine that you will have another class that pharmacokinetics? That
morphine.
is also asked, no? That like a morphine dosage, like that type question.
Pharmacy.
Yeah, pharmacy. You will have class on that, or
Yeah, that is basically, I'll tell you, the topic is that is something else. Uh, that is what, that is not molecular biology. That is
and that
molecular.
is pharmacy. Yes.
No, not even pharmacy. It is kept in something as basic sciences. Probably it's basic sciences, MRCP part one. So this is cellular biology. This molecular biology is cellular biology, cellular medicine. That part is toxicology and pharmacotherapy. Yeah, that is a different topic.
Okay. Okay. Mm-mm.
Pharmacotherapy and toxicology. That is a different class, two classes. Yeah, that is a different class. In that morphine, fentanyl, remifentanil, I don't know, blah, 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 blah. All these tramadol, everything is covered. Ethyl glycol, methylene glycol, presence in the urine fat droplets, crystallizes, ethanol does not crystallizes. यही कुछ आता है. These are poisonings, mainly because pharmacotherapy that is asked in the MRCP exam is asked from the clinical perspective. You should remember this. Whatever you study for MRCP part 1 and even for MRCP part 2, always remember that this exam is not a graduate level exam. It is a postgraduate level exam. So whatever you will be asked in context to applied form of medicine. That means how does it change the way you practice in your clinic? Are you getting my point? Because they want clinicians. They are taking exam for a set of people who want to become clinicians in UK. So whatever you do has to have a bent on the and a bearing on the clinical decision making. Always remember this. So whenever you are studying it, ask yourself, is what I am studying is going to have any bearing on the clinical side of it? If no, don't do it. Don't read. Leave it. Are you getting my point?
Yes, but even though we know the answer, sometimes the options are confusing.
I know. Like for example, in cystic fibrosis, I did not stress upon delta 508, did I? Because it is not a clinical context. Clinical context is knowing the drugs which which will be used in the management. Clinical context is how will you diagnose. See, I pressurized so much on diagnosing a cystic fibrosis right at the birth using trypsin, immunomodulatory trypsin levels. This is what you should know. Diagnosing by genetic testing. Which genetic testing? Microarray. This is why I'm saying, if somebody comes to you for a counseling, "Ki, I have cystic fibrosis, this is my wife, and we are going to have a child. What is guidance for us?" You tell them this is 508. How does it matter to them? Does not matter to them. You tell them how you are going to diagnose it. And if it comes out to be that, then how are you going to treat him? Then how are you going to follow him up? What are the complications which can present? And how will you treat those complications also? This is basically the crux of, this is why many people fail in MRCP, because they are looking at points which are not even relevant for a doctor. Are you getting my point?
Sir, sorry, sir. I have a doubt from the pharmacy, like this morphine part. Can I ask now here?
Yeah, go
D-
ahead, ask.
yeah, yeah. Because I attempted once, so I got a question. Like the answer was like after calculation, how will you convert it into morphine? But the question was initial daily dose of a day after calculation. So I know the answer is morphine was 10 mg BD. That was the one, but there were two options like 10 mg and 20 mg. So it was very confusing, like whether it is they are asking for whole day or the starting dose. Means like morning, what is the dose like that?
No, what was the case? Was it like cancer
We
Like
got
it was, it
self-medication?
question was a conversion. Conversion was a topic. Question was conversion, but the
Mm,
last they asked was like, what is the initial daily dose to be given at a day?
yeah,
So
converting morphine intravenous dose to oral.
yeah, no, like sir, sorry, uh, sir, question like converting into oral morphine. So
Yeah,
calculation wise,
from
we it is
intravenous.
easy. Yes, yes. So final answer was 10 mg BD. Answer we know it is 10 mg BD, but the question was like, what is the initial daily dose of day? So they are asking a question is difficult to understand whether they are asking the morning dose or for dose for the whole day.
Okay, so I will just give you a crux on morphine. So whenever you are using morphine intravenous and oral, so the thing
Mm.
is that you have to understand that the conversion ratio becomes 1:3. So if somebody is taking around, let us say, 10 milligrams of morphine intravenously, so the dose that you are going to give to that person is 30 milligrams per day. If it is 10 mg per day IV, then you convert it to uh, oral per day. Now, why oral morphine is required in more? Because of the liver metabolism, first pass. Because intravenously it bypasses the first pass, orally it has to go through liver. So, three times the dose is required. This is the number one that you should understand, that oral morphine is three times the intravenous dose. Even after that, even after that, if you have to answer a question, the dose has to be 75% of the calculated dose. This is very, very clear. It is worldwide norm. You convert it into three times for oral, and even in the oral, you give 75% of the dose. So, whatever doses are mentioned in the exam, it is given as per day dosing. Now, if you have to split it BD, that's a different thing. It will be mentioned. But if it is mentioned that what is the dose, that is a 24-hour dose.
Okay, thank you.
And even in that dose, you have to give 75% as the loading. Why? Because these are cancer patients. They may have hepatic metabolism also, which is not very great. So the consensus is to give 75%. Means if you say 10%, 10 milligram is the daily dose, you give 30. 30 ka 75%. What is 75? What? 25? No. What will be 30? 4 times is 6, 4, 6 fives are 30, 7 fours are 28. Something close to 7.2 milligrams. Now I don't know the question stem properly, so I cannot. But then this is the conversion system.
Yes.
Okay.
Thank you, sir. Thank you.
All right.
Thank
Okay.
you, sir.
Bye bye, everyone. Thank you.